Is Maya Luria with TMC for Seniors, and we are so glad to have you all here with us today. And this is our last brain health topic that we're going to be discussing. It is called Memory and Aging. How does it change? Why? And what can be done about it? I have Katie McVeigh here with me. She is with the University of Arizona's Department of Psychology. And I'm so glad that she is going to take this topic on. I know there is a lot to uncover, Katie, so welcome.
Thanks, Maya, and hi, everyone. Again, my name is Katie McVeigh. I'm a graduate student at the University of Arizona.
You go.
All right. Does this help folks?
No.
Okay.
No.
All right. My name is Katie McVeigh. I'm a graduate student at the University of Arizona. A clinical neuropsychology graduate student. I'm in my 5th year, so I'm almost done with the program.
No.
Still not loud enough? Okay.
It's not turned on.
Oh, the microphone is turned on. Is this better? Okay. I was going to say, I don't know if I can yell any louder than that. All right, we'll try this again. My name is Katie McVeigh. I'm a graduate student at the University of Arizona. I'm in the clinical neuropsychology program. I'm in my 5th year, so almost done, a couple years left. And today I'm going to be talking about memory and aging, as Maya said, how it changes, why, what can be done about it, but a little bit more specifically talking about normal aging, mild cognitive impairment, and dementia. So talking about those terms a little bit more, explaining what they mean, talking about some research and some current science on those topics.
Yeah, what you do need to do is keep it directly in front of your mouth.
Okay. Is this better? Okay. All right, so before we get into anything, I just want to take a moment to talk about how remarkable memory really is. It's pretty amazing that we can travel back in time, relive experiences we've had in our life, whether it was yesterday, a year ago, 20, 30, however many years ago. That we can close our eyes and imagine that we're back in those scenarios. And not only is it amazing that we can mentally travel back in time, but we can also use memory to imagine things that might happen in the future. And we can use it to imagine future events that haven't even happened yet. We can use our memories to help us make decisions, to plan. So it's really remarkable, all the things that our brain lets us do with memory. And I want to talk about a couple of things that in our memory research and working in a clinic, we tend to hear from folks when they're talking about memory and concerns and things that they've noticed. So an example of something we might hear is a gentleman who will say something like, I'm not as sharp as I once was. Sometimes when I'm having a conversation, I feel like the words don't come to me, or you feel like they're on the tip of your tongue and you just can't think of the word that you need in the moment. Or you might have a couple and the husband says, my wife tells me I forget things all the time, but I don't think my memory is worse than other people. She forgets things too. We're about the same. Or you might have a woman who says something like, my memory is terrible. I don't trust myself anymore. I feel like I can't remember anything. So there's a lot of different things that we hear from folks concerning their memory. And going back to the gentleman at the beginning, something that is common in normal healthy aging is difficulty finding words, especially when you're in a conversation and there's not someone to give you a hint, or there's not something to cue you of the word that you might need. That's something that is normal and healthy. And then with the couple example, he might be right. He might be having some memory problems. His wife may also be having some memory problems. And with the woman who is concerned about her memory, this could very well be concerning for her. It might indicate something, but it also might just be that she has kind of a lack of self-esteem, or maybe has unfair expectations placed on her by other people, or maybe she's expecting herself to be able to do things differently than she could before. And before we get into anything, I just want to cover what we'll go over today is to talk about the broad differences between normal cognitive aging, mild cognitive impairment or MCI, and talk about dementia. And then we'll talk about what causes MCI and dementia, common profiles among older adults, and then we'll end by talking about some of the current treatment options that are available at the moment and research on this topic. And so to start talking about what normal aging, healthy aging, this is from Dr. Elizabeth Gleski. She was at the University of Arizona. So the majority of older adults have healthy cognition, so about 80%. It's less common that individuals have memory problems or even dementia. Sometimes it can feel like that's more since it's talked about or it's something that we hear about often, but the majority of older adults don't have any memory problems. There are things that are normal in aging. You see changes in learning and memory, so it might take longer to learn things. It might take a little bit longer to remember what you wanted to. Changes in working memory. That's the ability to hold things in mind and mentally manipulate it. So if I asked all of you right now to do a math problem in your head, I won't, but if I did, that would be an example of working memory. Or if you think of a phone number and you have to hold it in mind before you go and you have to write it down. And things like mental speed, so how quickly you can do things, are areas where we see normal changing in older age. And then there are other skills that we actually see improve or continue to get better in older age. So it's not just that things continue to decline, things get better as well. Things like world knowledge and vocabulary are areas where we see individuals continue to improve as they get older. But there are a lot of individual differences, which is something that we'll talk about a lot in this talk. What's concerning for you might not be a concern for one of your friends or your family members or vice versa. And even if there are changes in cognition, if they exist, it could be an inconvenience in that it changes the way that you do things day to day, but they don't get in the way of you being able to live your life. You can still do everything you need to do, make bills, pay bills, make appointments, do everything, go shopping. Maybe some strategy changes in how you do that, but otherwise still able to complete things. So now that we talked about normal cognitive aging, I want to talk about dementia. And dementia is an umbrella term, and you'll see that there's a lot of different types of dementia that we'll talk about. Alzheimer's disease is the main cause of dementia, but there are a few that we'll touch on today as well. And there's only about 10% of older adults above the age of 65 who go on to develop dementia. So only 10%, it's not a majority of older adults. And one thing to know that dementia is not a normal part of the aging process. So it's not something that happens to everybody. It's very, like I said, 10% of individuals. And the medical definition that we use for dementia is it's a decline in 2 or more areas of cognition. And when we say areas of cognition, memory would be an area, processing speed would be another area, language skills, so those are types of areas of cognition. You see a decline in that, but you also see changes in how people manage their day-to-day tasks. So it might be that they need help taking their medications, or they need help getting to appointments on time, or they need help with other day-to-day things. And this is caused by damage or loss of cells in the brain, and it changes the way the cells in the brain connect to each other. And as I mentioned, Alzheimer's disease is the most common cause of dementia. It's about 60 to 80% of the cases that we see. So we talked about normal cognitive aging, and we talked about dementia, and there's another stage in between those two that is called mild cognitive impairment, or MCI, if you've heard that acronym before. And so this is a stage where an individual might have noticed that they're experiencing some changes, but it's not to the point where they need help with day-to-day things. They're still able to take care of themselves. They might notice some changes in memory, but it's not impacting their day-to-day function. Everything can still be handled independently. It just might take some new strategies or incorporating some new ways of doing things. And as you can see on this chart, the prevalence of mild cognitive impairment is fairly low. It starts to increase a little as individuals get up into their 80s, but it's still only about 25%. And it's a bit of an ambiguous clinical stage, as we say, because there's so many presentations people can have of mild cognitive impairment. As I mentioned earlier, there's a lot of individual differences. So there's not one size fits all in terms of this diagnosis. And of individuals who have MCI, only about a third of them over 10 years will progress to develop dementia. So just because you have mild cognitive impairment does not mean that you're going to go on to develop dementia, but it doesn't necessarily mean that you won't. So that's why we say it's kind of ambiguous. It's hard to tell. And just one thing to really hit home on this is that just because you have MCI, it's not definitive that you will go on to develop dementia. It's really dependent on the person, their medical history, and their individual differences. And here's a sense of where people or individuals that have Alzheimer's disease live in the United States. And you can see Arizona is a dark purple color, so that means there's a higher prevalence of older adults with dementia who live in Arizona. There's a couple other states where it's higher as well. So even though we talked about that it's pretty uncommon, it's about 10% of older adults who develop dementia, it might feel like it's more because we live in a place where people have a higher prevalence. And you can see there's some states where the rate is very low. Arizona is a popular state for this. And because the population of individuals who are going to be 65 and above is growing, it's expected that we'll see more people diagnosed with dementia over the coming years as there's more individuals. And I also want to talk about what doesn't differentiate all of these things. So what's similar between normal, healthy aging, mild cognitive impairment, and dementia. So these are things that just because you have one of these, that doesn't mean you will go on to develop dementia. It also doesn't mean that you won't go on to develop dementia. So concerns about cognition. Anyone who has healthy aging, who has mild cognitive impairment or dementia might have concerns about their cognition. There's a note here about subjective cognitive decline, which is just folks who, they feel like they're having some changes, but we don't see that on cognitive testing, or their medical providers don't see any signs of dementia, but they're starting to be worried about some things that they've noticed. So there's some research looking into if that might be a sign that some things are starting to change, and age. So as individuals get older, there's an increased risk for developing MCI or dementia, but just because you are getting older, that doesn't mean that you're going to develop either of those as well. Education is also a topic related to this. So typically individuals who have had more education or who had a greater more education or have a higher quality of education. That can be seen as kind of a protective factor for developing things like mild cognitive impairment or dementia. But again, just because someone had more education compared to someone who had less education, that does not mean that one or the other is going to signify that you're going to develop any of these. And biological sex as well. So there's differences in the rates that males and females have developed these diseases, but again, just because you're a woman doesn't mean you're guaranteed to go on to develop something. Same thing if you're a man, that doesn't mean you're going to go on to develop a different type of disease. So lots of individual differences, which is why the research on this, it's kind of hard to pin down what exactly would be treatments and how to best tackle these things. All right, so we covered kind of the broad differences between normal cognitive aging, mild cognitive impairment or MCI, and dementia. And now I want to talk about some of the most common causes and the profiles that you see among older adults who have these diagnoses. And the most common is Alzheimer's disease, as we mentioned, but there are a variety of other things that can cause MCI and dementia as well. Vascular disease is probably the next common, and there's some on that list that you might have heard before, like frontotemporal dementia, Lewy body disease, or Parkinson's, or some things that you might be familiar with. And I also want to point out what we call reversible or possibly reversible causes of MCI or dementia. And so these are things that might be leading to cognitive changes, but they are reversible. So these are important things that you want to make sure you're talking to your doctors about, you're talking to your medical care team about if you're experiencing any of these things and having cognitive changes, to see if it's something that they might be able to fix. So some things like medication side effects, infections, even things like depression can present as dementia. And I also want to talk about some of the pathology of Alzheimer's disease, and this will be important when we talk about the treatments. So there are two main pathologies in Alzheimer's disease. The first is amyloid plaques, and there are things called neurofibrillary tangles. And both of these things cause cortical atrophy or cell death, is another way to say that. And these amyloid plaques, it's an accumulation of protein in the brain, and they happen in neurons or the nerve cells in the brain. And these interfere with communication. So the nerve cells aren't able to communicate with each other with the amyloid plaques. And with the neurofibrillary tangles, this is another type of protein that blocks the transportation of nutrients between cells. So the cells aren't able to communicate with each other, and they're also not able to get oxygen, blood flow, those kind of things. And as you can see on the picture on the normal side, that is an example of what a brain would look like with no plaques or tangles. And then on the Alzheimer's side, we see the plaques and tangles between the nerve cells. And there's something called the amyloid cascade hypothesis, which is the current model of Alzheimer's disease. So this is how a lot of people think the disease plays out over time. And so the viewpoint here is that amyloid, one of the pathologies, first starts to develop. So you'll see on this graph over time, we have someone who is cognitively normal, and then they progress to mild cognitive impairment, and then they progress to dementia. And the curves indicate kind of the severity of some of these things. So the amyloid starts to come on board, and then we see the tau, or the other type of biomarker, start to appear in the brain. And then you'll see changes in the brain structure, and then you'll see changes in memory. So people might start having memory concerns or noticing changes in their memory. And that might be where they cross into the mild cognitive impairment domain. And then they'll have some changes in clinical function. So this might be day-to-day things. They need more help taking care of those tasks. And then they would fall into the dementia range. So this is the current idea of how they think Alzheimer's disease progresses in the brain. One thing to note is that even though we believe that amyloid is what kind of comes on first, that we start to see in the brain, the tau, so that blue line, the second one, kind of hard to see the colors, but that other biomarker is more closely related to cognitive changes. So when you start to see the tau increase is when you might start to see some of the cognitive changes that people are reporting. And we can also look at how these pathologies physically impact the brain. So this is an example of how the amyloid and the tau spread throughout the brain in someone who has Alzheimer's disease, and why it primarily affects memory. It also affects language as well. So on the left-hand side here, that little red circle in the middle is where the neurofibrillary tangles, or the tau and the amyloid start, and then they spread to the front of the brain and then progressively through the entire brain. And the reason that we start to see changes in memory first is that part of the brain where the dark red is the part of the brain that's responsible for memory and language. There's a part of the brain in that area called the hippocampus. If you've heard of that term before, that's the brain structure that is responsible for memory, language, and kind of knowing what words mean. So this is how it plays out in the brain and how the biomarkers affect our cognitive domains like memory and language. And just to give you a sense of some more examples of what normal cognitive aging compared to Alzheimer's disease might look like, these are some examples from Dr. Elizabeth Glisky, who was my undergrad mentor at the University of Arizona. So the first one, with normal aging, you might forget where you parked your car, but you don't forget that you drove there. You might have to walk around the parking lot a little bit, but you know that you chose the location. You might forget where you put your keys or misplace them, but you don't forget what your keys are for. You pick them up, you know that they're used to drive your car. You might walk into a room and forget why you're there. I do that all the time. But you don't walk into the room and you forget that you're in your house, or you don't forget that you're at TMC for seniors. You might forget people's names, but you don't forget their faces. You recognize them, you know that that's your friend, your family member. Maybe it just takes a second for the name to come up, especially if it's someone you don't see all that often. And sometimes you can't find the right word. It's on the tip of your tongue. It takes you a minute to come up with what the word you're thinking of, but you still know what the word means. If you saw it, you'd be able to explain what its use is. Or you're driving to your friend's house, you accidentally turn into the grocery store parking lot instead of turning down her street. But you can correct, you find your way to your friend's house. You don't lose your way, you don't get disoriented or kind of confused about where you are. And to talk about some other common forms of mild cognitive impairment or dementia. So as we talked about before, dementia is kind of an umbrella term. So dementia would be the diagnosis, and then Alzheimer's disease would be the cause of dementia, or vascular disease would be the cause of dementia. And these are some of the most common ones, Alzheimer's disease being at the top, vascular dementia, dementia with Lewy bodies, and then frontotemporal dementia are ones that you might have heard about before. And even though Alzheimer's disease is the most common form of dementia, typically it's also what we call not pure. So pure Alzheimer's disease would be that that's the only thing that's impacting someone's memory or someone's cognitive changes. But typically we see that mixed with other things as well. So it might be that an individual presents with Alzheimer's disease, but they also have some vascular risk factors, or they present with Alzheimer's disease and Lewy bodies. So it's not necessarily always just Alzheimer's disease. And as I mentioned, vascular dementia is another common cause of dementia. And one thing that we always like to say is what's good for the heart is good for the brain. Sometimes we think of them as kind of separate, but as you can see from this picture on the left, the brain is made up of so many blood vessels and arteries, and the blood and oxygen supply is what keeps our brain functioning. So the things that are good for our heart and what are also bad for our heart are the same thing for our brain. And there are a couple of different things that can cause vascular dementia. One of them is a stroke. And I'll just touch on the main two types. So there's an ischemic stroke and a hemorrhagic stroke. So ischemic stroke is where you have an obstruction in a blood vessel and the blood isn't able to get through, it isn't able to get to the brain. Or you have a hemorrhagic stroke, which occurs when a blood vessel or a vein ruptures and then it bleeds into the surrounding brain tissue. And these are some examples of neuroimaging of a brain of someone who has had a stroke or someone who has what we call white matter hyperintensities. So on the picture on the top, on the left, you can see it's pretty dark gray, and then there's an area of white where there's been some bleeding. And then the one on the right has an infarct, which is just a little small area. And then the brains on the bottom, these are different stages. So a mild, moderate, and severe. And you can see the area in the white in the middle grows as you go across. And white matter hyperintensities are usually due to reduced blood flow or degeneration of white matter, which is just a type of tissue in the brain. And this can be related to a variety of factors. So things like hypertension or high blood pressure, or other vascular risk factors too, like diabetes or history of smoking. And these vascular risk factors are associated not only with greater risk of having a stroke, but they're also associated with a greater risk of experiencing some cognitive changes or leading to cognitive decline. And I mentioned frontotemporal dementia. You might have heard about that with Bruce Willis. So his family announced that he was diagnosed with this not too long ago. And Wendy Williams, if any of you watched her talk show, she recently announced that she was diagnosed with frontotemporal dementia as well. It's a less common form of dementia. It primarily impacts language compared to Alzheimer's disease, which primarily impacts memory at the beginning. That's something you might have heard about in the news or might have heard about with some famous people. And I also want to talk about risk factors for dementia. And as we mentioned before, there's a lot of individual differences. And just because you have a risk factor, it does not mean that you're going to go on to develop dementia or mild cognitive impairment. These are things that just put someone at greater risk of developing something like that. So age is the primary risk factor. So as individuals get older, up into their 70s or their 80s, there's more prevalence of these things, but just because you're in your 80s doesn't mean you're going to develop this. Genetics is also something, so if you have a family history, if your mom or your grandma or aunt or your grandpa had Alzheimer's disease or another form of dementia, it's you at an increased risk of developing it. Vascular risk factors, as we talked about, high blood pressure, high cholesterol, diabetes, history of stroke, head injuries, another one, so if you've had traumatic brain injuries or a lot of them, that increases your risk. And disparities in healthcare and socioeconomic opportunities. So that means what we talked about earlier, differences in education. So maybe someone had a really high quality of education compared to someone who didn't have a great quality of education, or individuals who were in a lower socioeconomic status growing up. Maybe they didn't have opportunities to go to doctors or to get the healthcare that they needed throughout their life. And this is a little diagram from the Alzheimer's Association that I like about 10 ways to love your brain. So we like to say staying socially active, staying physically active, and staying mentally active are kind of the three components for healthy living in general, but also ways to love your brain. So whatever those things are to you, staying physically active as safely as possible, staying mentally active, if that's reading a book, that's doing puzzles, if that's taking a class at TNC on memory and aging, that could also be one.
Nothing about watching TV.
If you're engaged in a TV show, maybe you have conversations about the show, or you see a movie, it could be social engagement. Making sure that you're getting good quality sleep, getting enough sleep, protecting your head, so if you're riding a bike, making sure you're wearing a helmet, taking care of mental health, so if you're experiencing any stress, or you're feeling down or depressed, talking to someone, eating right, and making sure that you're staying socially engaged. So seeing loved ones, seeing friends, not getting too isolated. And to talk about the importance of social interaction a little bit more, this is an area of memory research that is a part of my dissertation, so something I wanted to selfishly throw in here and talk about a little bit. We know that social interaction is important for not only overall well-being and feeling happy and connected, but also for cognitive function. And we see this in domains like memory and executive functioning, which is a big term that basically is higher order cognitive functions. You can think of this like the CEO of a company. They are managing a lot, they are organizing, they're planning, they're switching back and forth between things, they're making decisions. Those are all executive functions. Things like verbal fluency, so how fast your verbal skills are, or processing speed, how quickly you can do things, are all positively associated with social interaction. Which makes sense. If you're talking to somebody, you have to, hopefully, you're paying attention to what they're saying, you're remembering what they say, you're planning ahead what your response is going to be. Maybe if you haven't seen someone for a while, you're remembering to ask them about the trip they went on, or ask them about something that they had going on in their life. And there's been some research to show that social engagement, so having more social engagement, seeing people more often, having a wide variety of social networks can help prevent cognitive decline over time. Not only is it good for well-being, it helps us connect with others, it can help us maintain a sense of identity. If we're meeting someone new, we're telling them about ourselves. We can also use social interaction as an opportunity to teach or inform others, maybe telling them about something that you learned, or if you had a terrible experience at a restaurant somewhere, remembering to tell them, don't go there, I got food poisoning, something like that. It can also be an opportunity to share memories, which is what I want to talk about a little bit next. And as I opened the talk talking about how amazing memory is, that we can, in our own mind, travel back to the experiences we've had in our own life, we can do that internally, but we also do a lot of memory sharing with others. So when we're talking to friends or family, or we're meeting someone new, telling them about the experiences we've had or things that we've done, is all memory sharing. And there is a particular type of memory called autobiographical memory, which is basically memory about yourself, fancy term for that. And not only is it the things that you've experienced, but also just facts about yourself, where you were born, your birthday, how old you are, how many kids you have, if you're married, things like that. And when we study autobiographical memory, we break it down into what's called episodic details and non-episodic details. And those are just fancy terms to say the things that people include when they share their memories. So it could be who they were talking to, where they were, what clothes they were wearing, what they remember smelling, how they remember feeling, or kind of background information that they're including to make the story more interesting or to give you some context. And we know that sharing memories not only helps us connect with others, we're telling them a part about themselves, people usually reciprocate, you're sharing an experience of something that happened to you. It gives an opportunity for more meaningful connection the more detailed you are. If you're telling someone a lot about yourself, it gives them a chance to maybe connect with it or learn something about you, gives them a chance to respond to things you've said. And interestingly, autobiographical memory is something that we see change as individuals get older. So the way older adults in a lab setting, when we have them come in, we ask them to share memories for research, they do it in a different way than younger adults. And we see that older adults tend to be less episodically detailed, but they include more of these non-episodic details. So that means they're giving more background information, they're giving you more context, they're telling you more about the people and their stories. And it's thought that this might be due to sort of the brain changes and just things that happen as we get older, kind of the way that older adults are sharing things, but it also might be a stylistic choice. They want to tell better stories. They're going to be giving you more background information because they've experienced more things. And this is something that research is looking into, figuring out how people share memories differently as they get older and what that might mean. All right, so far we talked about the differences in normal aging, mild cognitive impairment, and dementia. Talked about some causes, some profiles, and I want to end by talking about some of the current treatment options that are available at the moment. And there's a few different things to talk about. So there are medications. You might have heard of some of these, or you're on them, or you know someone who takes them that treat mild cognitive impairment or memory changes, or people who have dementia. One is called Aricept. There's another called Memantine, if you've heard any of those names. There's also cognitive rehabilitation. So those are practicing different cognitive strategies, doing brain games, seeing if that can help improve areas that people are struggling with. And this is something that's being researched, trying to look at different technologies that could help people do this in their day-to-day life more easy. There's other strategies that are being researched that seem like they're showing promising outcomes as well. And as we talked about before, some of the really important things that seem like they're pretty simple: physical exercise, social engagement, and cognitive engagement. So using your brain and doing different things. And I want to talk about some things that have been in the news recently over the past couple months, even the last few years, that you might have heard about. So one is about how we are diagnosing Alzheimer's disease. So years ago, this used to be something that could only be done post-mortem via autopsy. So after someone died, they would look at their brain and you would be able to see kind of the shrinkage in those areas we talked about. But now there are ways that Alzheimer's disease can be concretely diagnosed while people are still alive. You don't have to wait to do an autopsy. And those are using those biomarkers that we talked about earlier of amyloid and tau, those things that we see form in the brain. And there are a few different ways we have to measure these. One is through cerebrospinal fluid, CSF, which is collected through a spinal tap or a lumbar puncture. So not exactly a fun thing that people want to have done very often. There's also neuroimaging through MRIs or a PET scan that can show the amyloid or tau in the brain. And there are also biomarkers that will get collected through a blood draw. These are typically done for research studies, so not necessarily something you can go to your doctor and ask for. And these tests aren't for everybody. Some people can't get a lumbar puncture, some people can't do neuroimaging. Some of these things are also expensive and insurance won't necessarily cover those. So they're not all options available to everybody. And as I talked about neuroimaging, there's one kind called amyloid imaging, which is done through a PET scan. So this looks at the levels of amyloid in the brain, which is one of those biomarkers we talked about. And if you're looking at the pictures, on the left-hand side is someone who is cognitively healthy. They don't have any Alzheimer's disease. They don't have any pathology. And then the two on the right-hand side are individuals who, with the red, you can see that they do have amyloid in their brain. And so that's someone who has mild cognitive impairment on the left-hand side of the red, and then the right-hand side is someone whose brain has Alzheimer's disease. And you can also notice that that brain looks like it's a little smaller. It's looked like it's kind of shrunken a little bit, and that's the cell death, some of the cortical atrophy that we talked about earlier. And there are also anti-amyloid treatments, and you might have heard about some of these in the news over the past couple of years. So these are drug treatments. The first one we'll talk about is called aducanumab, which is a mouthful. And this was first approved by the FDA in 2021. And this helps clear amyloid in the brain. So it takes those amyloid pieces out of the brain that we showed earlier. But there are some risk factors. As it's removing amyloid from the brain, there is a risk of brain swelling and bleeding at the places where it takes the amyloid out. It also is an infusion, so it's not a pill. It's something you have to go into a hospital or a clinic. They hook you up. They do an IV infusion. So it takes a while. They're also expensive, and at the moment it's not covered by Medicare, so it's not something yet that is easily accessible to everybody. But it is showing promise in that it does remove amyloid, and it does seem to slow down some of the cognitive changes that people report with Alzheimer's disease. And another one of these anti-amyloid treatments is called lecanemab. This does something similar to aducanumab, where it takes the amyloid out of the brain. We still see the same issues with brain swelling and bleeding that we see with aducanumab, so there are some side effects. But it has shown good clinical implication. On that figure there, the blue line is someone who's not getting the drug. The orange yellow line is someone who is getting the drug, so you can see they are above the blue line, so they're doing a little bit better than someone who didn't have this treatment. But same as the other one, it's still expensive. It's not easily accessible by everybody. One thing to add about some of these anti-amyloid treatments is they're still being developed. So even though they're not widely accessible, the research has come a really long way in terms of what we can do to treat. So even though we haven't found the cure yet, we don't necessarily have the answer. Compared to 10, 20 years ago, they've made a lot of progress. So we're hopeful that they'll continue to develop things that could work even better than the drugs that we have so far. And a lot of the anti-amyloid treatments are also available only through clinical trials research, which might be a reason you haven't heard of it before. If that's something that you are interested in, maybe learning more about, you can always talk to your primary care or your medical providers if that's something you'd be interested in getting involved in that kind of research, or if you know someone who might be interested in that. All right. So just to cover what we've talked about so far, talked about the differences between normal cognitive aging, NCI, or mild cognitive impairment, dementia, talked about the different causes, Alzheimer's disease, vascular dementia is a couple, and talked about some treatment options as well. And before we turn it over for questions, I just want to plug my lab's research. So we have a project going on called CARE, and we're looking at improving the way that we assess cognition in older adults. You come into our lab, we do some paper and pencil cognitive testing, we do some other lab tasks, we do an MRI, and some blood samples as well. And if that sounds like something you're interested in, we are recruiting. We're looking for individuals to join our study. There's a phone number there if you have any questions or you would like to learn more. You can also email us at uaaging@gmail.com. Or if you have your smartphone and you want to take a picture of that QR code, it'll take you directly to the screening form that gives you some more information and lets you fill out our form to be contacted.
I've got a question.
Yes.
I'm 97, should I be bothered even worrying about this? I'm reasonably functioning.
I think if you don't have any concerns, obviously things come up, you want to talk to your primary care, but there's nothing that's concerning to you. And there's nothing no reason to get worried about something that you're not
I'm not worried.
about.
So, Katie, I know people can't see me, I'm normally online. I do want to just share, or I got a question that came in, and it's regarding brain supplements. So we see those people are always promoting the boosting miracle pills that are gonna help you with your brain health. Has there been any research on these supplements and for brain health? Have you guys seen that over at the Human Memory Lab or?
Yeah, so as far as I know, I haven't seen any clinical research that has looked at those brain supplements. I know some of them, they give a lot of benefits. So if it's something that your doctor approves of you taking and you like taking it, make sure you check with your medical providers. From a research standpoint, I haven't seen anything about if those are as effective as some of the other things that we talked about.
Okay. And can you share a little bit more about what actually happens in the Human Memory Lab? Because I think that's fascinating.
Absolutely, yeah. We always have, the CARE study is something that we've had going on for a while. So we do mostly in-person studies. They're all in person. We were on Zoom for a little bit during the pandemic, which was interesting to do all of these tests online. But we do research looking at how memory changes across age. We also look at memory sharing, which is something I talked about earlier, and how people share memories with each other. We also have a bunch of research writing that goes on, so working on publications. We have a very large team of undergraduates who work in our lab that help us with data analysis, data synthesis. So we do a lot of different things.
Great. I want to go ahead and wrap up with our online audience, and then we'll turn it over to our in-person. So thank you so much for being here today, Katie.
Yeah, of course. Are there any questions I can answer? Yes.
Would she